Good afternoon to you and welcome. Why has there been such a dramatic increase? If it is a dramatic increase, 55%, you'll have to educate me.
Good afternoon. Thank you for giving me the opportunity to join you this afternoon. I think we just need to understand that the 55% is compounded over 5 years. When you look at an average per annum, you see around 8% increase, which is still higher than inflation. But the 55% is compounded over these 5 years. And really, what is the key driving factor here is what we refer to as benefit design. So when you look at your medical aid options, you realize that there's nuanced differences across these options. Some of them have benefits in hospital and out of hospital, and they cover these services at different rates, scheme rates. And then at some points, you need to use designated service providers and networks and not. And these nuanced differences tend to really impact on how much you find yourself having to spend out of pocket without probably being aware of it most of the time.
If you look at the big picture, Manini, it suggests that people who are lucky enough to afford private healthcare need to think beyond the scheme itself at other ways of protecting or funding their medical expense. Is that an incorrect interpretation?
Well, I think as the council, we are for universal health coverage. We don't want beneficiaries to feel that healthcare is a catastrophic event when they eventually need to access healthcare. That this is catastrophic to their savings and their finances. We want them to get bang for their buck, to get what they're paying for, and so. I think what we are really working hard on at the moment is ensuring that any kind of surpluses or savings that medical aid schemes find themselves with are directed towards benefit enrichment, such that this issue that I just explained of benefit design is not so catastrophic on members. So we want to see this channeling of savings and surpluses towards enriching the benefits of members as a whole. So it's not incorrect to say so, but I think we don't want it to be that way. We want access to healthcare for everyone at an affordable price.
Fair enough. So a final question to you and a brief answer, if you don't mind, sir. If the funding out of our own pockets has jumped by this amount of 55%, I understand extrapolated over time, what exactly are we spending that money on? In other words, what is the most expensive item?
Medicines dispensed is a key driver, and I must point out that there are regulations in place to regulate the price of medicines in the form of a single exit price that was introduced in 2004. But we must remember that there's all these pharmaceutical issues of generics versus biologics and patent medicines, and I think that those are really what drive the cost of medicines for beneficiaries at the end of the day. So medicines continue to be a key driver, as well as total hospital and specialists. Those tend to really continue to drive, especially when you look at that own spent, that money that comes out of your pocket over and above the medical aid savings. Those tend to be really, really key contributors.
And I'm going to leave it there. Manini Molatseli, thank you very much indeed from the Council for Medical Schemes.